I'm Dr. Laura Swoboda, a family nurse practitioner, wound specialist, and translational scientist from Milwaukee, Wisconsin. Today I'll be presenting a case on a right lateral calf skin tear. So this patient presented to my outpatient wound center complaining of a skin tear. She didn't remember the injurious event, but her spouse did. He explained that she had fallen and that they had placed a bandage. When he removed that bandage at follow-up to take another look at the wound, he removed it in the opposite direction and actually pulled off the skin flap that had initially been in place, accidentally. She has a past medical history as an 81-year-old white female accompanied by said spouse. She's immunocompromised, and that is from a renal transplant due to end-stage renal disease. That end-stage renal disease was due to a hereditary polycystic kidney and liver disease, and the steroids given post-renal replacement unmasked type 2 diabetes. So they also have atrial fibrillation, hypertension, hyperlipidemia, a pacemaker in place, and a history of gout. Here are some of the medications that she's taking. So looking at this medication list, I'm considering the effect of polypharmacy on the risk of skin tears. So I actually highlighted in red here the medications I'm familiar with that impact at the tissue level one's risk for skin tears or for delayed wound healing of those skin tears and complications of those skin tears. And then in blue, medications that can cause maybe altered balance or sensation or a risk of skin tear from a cognitive functional standpoint, or medications used to treat disease states that can cause cognitive and functional etiologic mechanisms of skin tears. So this is what the wound looked like at presentation to me. The wound measured 7 by 6.5 by 0.1 centimeters. That's 45.5 square centimeters. A pretty big wound for that area of the body, the lateral calf. In a healthy weight person. Looking at her peri-wound, I can see some senile purpura. It may have happened during the initial wounding event, but we can see they're kind of scattered around and she's susceptible to them anyways. I can see a lot of skin atrophy. The skin looks very, very thin. It has a tissue paper quality to it. And I can see some, I believe, cribriform scarring up at the very top there. Looking at the wound itself, there's a full separation of the dermis and the epidermis, and unfortunately a complete flap loss, though that did not happen at the time of the skin tear. So this is a little question mark, right? I'm not sure about the nuts and bolts of it. I called this an ISTAP type 3, but for your consideration given that caveat. So my treatment plan for this patient was soap and water cleansing, followed by hypochlorous acid and non-contact low-frequency ultrasound treatment. For a topical dressing, we use a next-generation silver dressing, so silver with BEC and EDTA, and then followed that with a silicone-bordered foam dressing, and then had her follow up in 2 weeks. The reason that I chose more than I would normally do for a skin tear, so my kind of normal bundle for a skin tear would be the soap and water cleansing, hypochlorous acid, and then a silicone bordered foam dressing. But for this patient, she had a history of multiple wounds, of delayed wound healing, had an extensive medication history placing her at risk, and a lot of comorbid diseases placing her at risk. So I wanted to give her the best bet of healing well and not suffering from the risk that we know she's susceptible to. And so this is what that looked like at the 2-week follow-up for this patient. And I was very pleased. So when I'm looking at this, I can see First of all, a lot of subcutaneous tissue atrophy, but that's separate. Looking at the wound bed itself, the edge of the wound appears to be attached and migrating inwards, like epithelializing. And then the granulation tissue is bright beefy red. Now this image was before cleansing, so you can see that coagulated fibrin / biofilm kind of goo that will form, that a good cleansing should be taken care of if you're doing it properly. So I say if it's not broken, don't fix it. Given the positive findings to me at that 2-week follow-up, I said, let's keep doing it. Let's go 1 more week. So we continued that same plan of care. And at the 3-week follow-up, it looked fantastic, nearly epithelialized. It's 1 by 1 by 0.1 centimeters, and it's really just that little bit in the middle there where there's a tiny bit of granulation tissue poking through, a little moisture, but otherwise epithelialized for the most of it. So even with her extensive comorbid diseases and polypharmacy, able to see quite a substantial improvement. And looking in conclusion just at this final side-by-side, you can see what it looks like at presentation and in consideration of all of their risk for delayed wound healing and wound complications, what it can look like with good proactive wound management in a short period of time. So this would be what healing would be expected in someone in their early 20s, and we were able with good wound management to achieve that outcome for this patient.